we hear about health reform, starting with Hillary Clinton in the previous Bill Clinton era, going all through those last, now nearly 16 years to today, what has the debate been around? It's been access to care and reimbursement. Who's going to pay for surgery? Who's going to pay for drugs? Who can get to the hospital first? Do we have health insurance for all people, or are we discriminatory? Now, these are all beneficial reasons for debate. I'm not suggesting we should throw the baby out with the bathwater. However, I hear very little discussion about what drives people to hospitalization and to surgery and to pharmacotherapy. It would be interesting, would it not, entertain the question, where did disease come from? We have moved, as our culture, in the last 50 years, from a culture where disease patterns were principally acute diseases to where the principal disease patterns today are chronic disease. 78% of healthcare expenditures today go to chronic disease management. Number one on the list is type 2 diabetes, with all the attendant secondary side effects. Renal failure, ocular injury, neurological problems, you know, all the things that happen as a consequence of diabetes. Cardiovascular disease as well. But beyond that, we've got increasing incidence of certain families of autoimmune disease, particularly systemic lupus erythematosus is on the rise, thyroiditis is on the rise. I could go down the list. Chronic digestive disorders, esophageal reflux disorder. You can't really even be a fully functional 40-year-old unless you can talk about your esophageal reflux disorder, right? So, I mean, we have so many functional problems that are precedents to the later stage acute disease where we only spend 22% of our healthcare dollar, but our medical doctors in training spend 95% of their time learning how to manage those acute diseases. So as Halstead Holman, Dean of Stanford University Medical School, says in a wonderful editorial in the Journal of the American Medical Association in 2005, he asked the question, are we in need of a new clinical education? A new clinical education that focuses not just on acute care medicine involved with hospitalization, but the chronic disease ambulatory care model. The model that you know is a difficult model to apply because people generally don't get immediately well. They don't have self-limiting acute disease. They either die or get well. They stay in a chronic state of infirmity with functional disabilities. Now let's take one such example, Alzheimer's disease. A very interesting example, is it not? Alzheimer's disease is a kind of a nice, what we call medical taxonomy. It's a term. It's like Linnaean biology. We always feel better if we can call something something. I mean, it's like, okay, now you say that that person has Alzheimer's. What do you do for them? Well, we have these wonderful drugs like Tacrine or Aricept. These are horrible drugs. They're horrible drugs. You're looking at the scientific papers that have been published in the most premier journals, the Journal of Neurology, the New England Journal of Medicine. These drugs don't work. You know that if you've ever seen Alzheimer's patients, that these drugs are poor drugs. So where did Alzheimer's disease come from and where is it going? It's said right now at the rate of increase of Alzheimer's dementia in our population that over the course of the next 25 years, it will take almost 40% of the healthcare dollars just to manage Alzheimer's patients. So we become an aging America of infirm people, putting a burden on a society of younger people who are limited in number through this pig in a python called the baby boomers. So all these aging post-World War II baby boomers are going to be supported in Alzheimer's clinics by a few number of young working people, all who are chronically ill, because now what we find, I'm now quoting from Kostokov's book, by the way, called The Coming Demographic Storm. And in that book, what he points out is that if you look at the younger people of this country, I'm now talking about teenagers and young 20-year-olds, that their health patterns are horrible. In fact, the New England Journal of Medicine published a paper again in 2005, some of you know this, which was a wake-up call to all of medicine saying, based upon what is going on right now with our youth, the suggestion is that this will be the first generation born in the history of the United States who is expected to live shorter than their parents. That's when we're spending twice per capita on healthcare. Now, these are all wake-up calls. I'm not making these figures up. This is not my interpretation. These are in the highest quality, peer-reviewed medical literature. Whether you're a healthcare planner, a policymaker, a medical educator, a patient, a provider, this is a sea change, as Dr. Brazono was talking about, that we're confronting. So now that's the alarming news. The good news, I want to give you the cup half full now rather than the cup half empty, is that on the other side, we are for the first time starting to uncover the origin of chronic age-related disease. There is a new biology that's emerging, rooted in epigenetics, rooted in the Human Genome Project, rooted in molecular medicine, rooted in functionality, so that we don't wait till a person is so broken that what they need is an organ transplant or to be put in a terminal care facility. We look early on when the trajectory of that dysfunction is such a level that we can modify earlier rather than later. Because once you get to later, you know the problem. It's heroics. And we keep people held together with baling wire and bubble gum the best we can. Now, I'm involved with some research involved with biotechnology and some cancer research. I go to these big biotech conferences. And it's been alarming to me. Maybe I've got a problem, so I'll just share it. I'll offload my problem to you. The problem is I go to these very, very remarkable high-tech discussions with the scientists from the world's class institutions who are talking about this major breakthrough they've had in managing a specific form of cancer with a new drug, something like a kinase inhibitor, in which they're talking about the fact that on average this drug, which will cost $3,000 to $4,000 a week, will extend mean life expectancies by 2 weeks. Now, what is this all about? By the way, I'm not making this up. This is true. And these drugs are being approved. Now, maybe some person will have the luck of the draw because they're the outlier, or they'll have complete remission. But on average, the benefit that you can tell that patient is, we're going to give you 2 more weeks of life. By the way, it's also going to have serious side effects during your 2 weeks. So the point I'm trying to say here is that we're caught up in a very interesting conundrum. We have these tools for the first time that can allow us to understand the origin of disease way earlier than we've ever been able to understand it. Starting the root origin of dysfunction well before you get pathology. But what we do in our medical system is reward people for doing the most at the terminal end of life. In fact, in our culture, if you aspire in medicine to be financially successful, you want to be trained to do the weirdest things. Right? The more you can intervene with bizarreness, the more you will be valued. Doing simple things like telling a person how to exercise, eat right, live right, manage stress, change your environment, that's like, oh, low tech. That has no value. That's like public service stuff. The real stuff is doing things that no sci-fi movie 30 years ago would even think was reasonable. That's where you really get the great reimbursement, because you must be pretty good to be able to do that stuff. So what I'm suggesting to you is that the whole value system we have to aspire for young minds who are brilliant to be realized as great is reinforcing more doingness of bizarreness and less enlisting that genius, that creative understanding to keep people from needing bizarreness. Now, if you don't understand what I'm saying, let me give you an example. I'm going to show a quick little video vignette. We are fortunate. We see a lot of patients out in our Gig Harbor facility, and we see patients